Bom dia a todos. Essa é a reunião clínica da disciplina de Nefrologia do Hospital do Rim, da Fundação Oswaldo Ramos. Nós estamos comemorando agora, o ano passado nós comemoramos 25 anos, agora nós vamos comemorar todos os anos. Esse ano nós estamos comemorando 26 anos. Nós temos a honra de contar aqui com o professor Marcelo Cantarovich. Ele vai falar sobre aumento da utilização de rins, que de outra forma seria descartado. A professora Maria Gervásio está presente também agora. O Dr. Marcelo, ele é graduado em Medicina na Argentina, na Universidade de Buenos Aires. Ele está há 24 anos na Universidade de McGill, no Canadá. Ele é diretor do Programa de Transplantes na unidade. Ele é diretor do Programa de Transplante Renal na McGill. Ele é professor de Nefrologia na McGill. E a pesquisa dele está bastante enfocada hoje em educação, tanto nacional como internacional, relativa à doação de órgãos. Além disso, o Dr. Marcelo é filho do Félix Cantarovich, que o Walter conheceu bastante, o Mário Acute, que está presente, também conheceu bastante, e nós tivemos uma relação muito boa com o seu pai, que é o Félix Cantarovich. E ele vai falar sobre... então, aumento da utilização de rins, que poderia de outras formas não ser utilizado. É um honor muito grande para nós outros tê-lo, tá? E eu penso que ele deve gostar muito de estar aqui em São Paulo. Muitas graças por tê-lo aqui.
Muchas gracias, José. Muchas gracias. Thank you so much for this invitation. It's a great pleasure to be here. But before I start, you mentioned my father, and my father was alive and still working from the angle that he's interested in. Many people don't know. You heard of the Spanish model, and Spain started doing many transplants in the late 80s, in the 90s, early 90s, and it's at the top now, with the US as well. If you look at the number of transplants performed per million inhabitants, but it's something that some people know, but many people don't know. When I went back to Buenos Aires, I did my residency in internal medicine in Buenos Aires. 84, I finished in 84, and 84 to 88, I went to Paris for my nephrology and transplant fellowship. But when I came back to Argentina, my father was organizing courses for Latin America about transplantation, in particular transplant coordinators. So he kind of created the transplant coordinators that you hear, that everybody, they're used everywhere. And in those cases, they were psychologists. Why psychologists? Because transplant was kind of new, talking about late 70s, early 80s. And we needed to have the agreement of the family consent. And as you can tell, in Brazil and Argentina, Latin America, we have a similar culture of religion, yes, no. And there were people from all Latin America attending transplant coordinator, how to manage, how to identify an organ donor, how to manage a donor. But there were people from Spain coming. And in those days, the number of transplants in Spain was not great. And they have a fantastic model, but many of the ideas came from my father when he started with the project of the transplant coordinators and trying to identify donors, etc. So I just would like to give a tribute to my father because he really deserves it, and not many people know that. So the title of this presentation, the title that I like is the use of kidneys that nobody wants. And so what is the percentage of the global organ transplantation needs that are fulfilled? Do you know? I showed it yesterday, but some people weren't here yesterday. Do you know? 100%, 50%, 0%? What do you think? Let's give a number. 10%. Excellent. So less than 10% of the global needs are fulfilled. This is after the Global Observatory on Donation and Transplantation from the Organización Nacional de Transplantes from Spain and WHO. So should we increase the kidneys that nobody wants? So here you have 60% of donors who are expanded criteria. Do you think we could increase the number of transplants that are done based on sometimes quote unquote marginal organs, marginal donors? Do you think we could? Can we try? Or you think we are okay? What do you think? People are nodding. Okay, so people are thinking that we could try. So at the end of this presentation, I just hope that you will feel comfortable considering increasing the use of marginal or kidneys that nobody wants. We don't use the word marginal donors. They used to be called marginal donors, then they became expanded criteria donors. So this is an outline of the presentation. So I will be asking you questions, so I would like you to speak up a little bit. So here we have a 78-year-old woman, a donor with a stroke, which is an expanded criteria donor by definition, with a GFR of 91. I didn't include the blood group, but we could. The recipient is 72-year-old man, diabetic, 3 years on dialysis. Would you accept this offer? Let's say blood group A, 0% PRA, blood group O, 0% PRA, or blood group B.
Depends on biopsy.
Depends on biopsy. I think that at the end of the presentation, I think that the pathologist will have to retire.
I'm close to that.
No, but maybe you'll do something else. Well. Okay, so would you accept this offer? Let's say, who's on call today? No one on call?
Accept.
You accept. Okay. Do we have anyone on call today? No one on call. So would you accept? Here we have a guest from the Netherlands. Let's say a local people from Sao Paulo. Depends on biopsy.
We accept the offer, but we will accept the kidney.
Wow.
And we will do the transplant if the biopsy is okay.
It would be great. Just wait a few more minutes. People from the audience, can you hear me?
Yeah.
People who are virtual.
Yes.
So Walter, would you accept this offer? They don't hear me.
I can hear you. I can hear you. I do accept it.
Accept.
Yes, you would accept. Okay. It's okay. It's good that we keep it interactive. Thank you. So we accepted the offer. There was immediate graft function. Okay. Residents. Who are the residents around the table? We have any resident here? No resident? Everybody finished the residency already? Wow. Okay. Immediate. So what's immediate graft function? Okay, and what else? That's
Within 3 days,
shorter, 1 day. So the creatinine decreases, this is a US definition, more than 20% in the first 24 hours. What you mentioned is slow graft function. So look at the GFR at 3 months, 58, which is more than half of the donor. GFR is great. A little bit more complicated now. So now we have an ECD with a cardiac arrest that you don't do. So GFR 115, the recipient 55, polycystic kidney disease, could be blood group A, B, or O, and depends on the PRA. We could expand and make it very interactive, but you don't use, so far, DCDs. So you would not accept this offer, but look, the recipient at 1 year had almost half of the, even though the recipient experienced delayed graft function, defined as, Niels? Delayed graft function? In the first week, perfect. Even though the recipient required dialysis in the first week, had a GFR which was not close to half, but close to half of the donor GFR, which is great. And I will show you this tomorrow. So now we went from an expanded criteria to an expanded criteria and DCD, and now expanded criteria, DCD and diabetic donor with a GFR of 96. You won't accept it because of the donor is DCD. But let's say that the donor were not DCD, expanded criteria and diabetic. Would you accept it? Forget about DCD for now, but would you accept it? Expanded criteria and diabetic, GFR 96, depends on the biopsy.
Yes. The tendency is the trend is to accept this GFR.
Okay, you will have to convince me, my friend. So the recipient experienced delayed graft function, but look, at 3 months, the GFR was almost half of the donor GFR. I'm not going to show you that. It's a paper that we published about organ function, kidney function recovery. But with that recovery, the long term of the kidney is excellent. So that about the organ procurement transplant network in the US. Here you can see the green line showing the number of people over the age of 65 that have been listed from 2010 to 2022. As you can see, that you can see the green here, it's slowly going up. So we have a higher number of older people on the list. Then, if you look by diagnosis at the top, diabetes. Then, adults that would accept an expanded criteria donor kidney or high KDPI over 85%. Some people may not use it, but let's just think about an expanded criteria donor. Look, the top line, green, represented by the people over 65, over 60% are willing to accept such an offer. What's the mortality pre-transplant of people on the waiting list? So you can see yearly mortality has declined a little bit, but remains stable. And at the top are people over the age of 65. So about a bit more than 8% mortality per year. And then you can see that it's higher, as we all know, in diabetics. Here you can see the percentage of kidneys that are recovered and not transplanted. 30% in 2022. And if you look at the kidneys that are recovered and not transplanted, you can see that those over the age of 55, donors over the age of 55, 50% are recovered, are not transplanted. 55%, 50%. So what are the reasons why kidneys are not used in the United States? Diabetic donors, 50%. Hypertension, 40%. Terminal creatinine over 1.5, 40%. As you can see, these are many of the criteria for the definition of expanded criteria donors, and also included in the KDPI calculation. Here you have the biopsies. So what is the percentage of kidneys that are recovered and not transplanted because of the biopsy? 35%. A pathologist in Canada said, If you would like to find a reason to refuse a kidney, do a biopsy. I let you think. Look at this slide. What's the current percentage of organ refusal because of hepatitis C positivity? And you can see that it has declined since 2010. It was 40%. It went down to 30%, mostly because of the treatment that became available. And then the donors that are at high risk of transmission of diseases is another reason for refusal, about 25%. 20 to 20%, those who are, you see that there is no, the standard risk is 20, the standard risk is 25%, and the increased risk is a bit lower, the refusal. It's interesting. So donors with circulatory determination of death, the purple line is 30% compared to about 20% of neurological determination of death. And then those who with a high KDPI, the top line over 85% represents 70% of refused kidneys. So you all know what an expanded criteria donor is. You can see the definition on the screen. This is a slide that's now 20 years old, but you can see that it portends a poor prognosis. 51% graft survival at 5 years compared to 68 with a relative risk of graft loss of 1.7. Excuse me. But one of the important things, as I will show you shortly, is if there is organ recovery. We talk about that. On the left, you can see the outcome of patients that receive a kidney from an expanded criteria donor compared to those on the waiting list. What do I mean? Anything above this line shows an increased mortality risk for those who receive a kidney from an expanded criteria donor. And there is an equal risk to those on the waiting list at 226 days. After that, there is a survival advantage. Anything below the line, at 3 years, 17% survival advantage compared to remain on the waiting list. Again, this is mortality after receiving a kidney from an expanded criteria donor compared to staying on the list, on the waiting list. Data from France from 2007, if you focus at the right lower quadrant, you can see survival on dialysis 67% compared to an expanded criteria donor 84%. This is a metric that has been used in the US. It's a KDRI, Kidney Donor Risk Index, and you can see all the variables on the screen: age, ethnicity, creatinine, hypertension, diabetes, cause of death, height, weight, DCD, HCV, and then transplant parameters, HLA matching, cold ischemia time, and block or dual transplants. And the higher the KDRI, the lower the median graft survival. For instance, here you can see low KDRI, 14 years of half-life, median half-life compared to 7.5 with a KDRI over 1.4. Do we use it at our institution? We don't use it. This slide shows that with increasing donor age, after the age of, there are many people in the 30s here, so after the age of 30, so there is an increased hazard ratio of graft loss when the donor age increases. This is a slide from the US looking at the Kidney Donor Profile Index, KDPI, and the 10 variables are listed on the slide. You can read them. And at the bottom in the figure, you can see the half-life of a living donor, and then the half-life of a KDPI of over 85, 5.6 years. So is there a survival benefit when using kidneys from donors with a high KDPI? And this is work by Doris Segev's group. And you can see, again, anything above the red line favors to wait for a kidney, and anything below the red line favors to receive a kidney transplant. And as you can see, there are three lines from left to right. The black line represents KDPI over 70, and it takes about 6 months to observe a benefit. And then KDPI over 81 or over 91, it takes a year. But then there is a survival advantage. So should I use this donor? Well, the benefit is in recipients over the age of 55 and on renal replacement therapy for over 33 months. But here there is a little nuance. 33 months on dialysis and 33 months listed. Because if we have someone, blood group, if B or O, that takes longer, with a 0 PRA, if the donor is very, very, very high risk, it's a high risk, we may not consider it if the recipient was listed a week ago. But if the patient has been listed, or it's difficult to use this criteria, but I take it as time on the waiting list rather than time on dialysis, depending on the access to transplantation in your jurisdiction. So this is the data from Lillian Gaber, pathologist married to Osama Gaber, transplant surgeon, and a friend, former president of the American Society of Transplant Surgeons. And this is where the 20% data is coming from, 20% glomerulosclerosis. So focus on the right figure. Here you can see the percent glomerulosclerosis from 0 to 70. And then you can see the kidney function in serum creatinine at 1 month, 3 months, and 6 months. So with increasing glomerulosclerosis, there is increasing serum creatinine. Okay, yes. That's what we are using, right? But there is more data. So this is a bit more recent data from Randy Sang and others. And you can see these were kidneys from expanded criteria donors that were pumped. On the left, you can see the percent glomerulosclerosis from 0 to more than 20%, the relative risk of graft failure, and the p-value. So no risk of graft failure, no increased risk of graft failure using kidneys with more than 20% glomerulosclerosis. If you look below, well, yes, there could be a difference in the kidney function, obviously. Here you can see that those with a GFR, glomerulosclerosis less than 10% had a creatinine clearance at 1 year of 41.5, and those with a glomerulosclerosis over 20%, 39. So it was statistically significant, but is it clinically relevant? There was no difference in graft survival. And here, this is a systematic review by Bert Kasiski from 2015. They look at 14 studies. And as you can see, this is a summary. In half of the studies, the percent glomerulosclerosis could not predict graft failure, 50-50. It could not predict post-transplant outcomes. And more importantly, there was no semi-quantitative data scoring system that could predict post-transplant outcomes. And the conclusion of that paper was that the routine use of biopsies to help determine whether or not to transplant a kidney should be re-examined. I'm not sure that we have the final word. I showed you clinical vignettes with good GFR. I'm showing you that if the kidneys were pumped, I don't know if there is data about non-pumped kidneys. I know that you don't pump, so I don't know how would they behave. But kidneys that are pumped from expanded criteria donors don't have an increased graft failure, even if the glomerulosclerosis is over 20%, because what matters is the function. And then if the patients don't get a transplant, they die on dialysis. Maybe we can stop a little bit here. I'd like to hear your comments.
There is a bias when you analyze biopsies to predict outcome, because you're just looking at those kidneys that were transplanted and not those that were discarded.
Correct, but the
You
tension.
should see and compare those that were discarded, whether they behave similarly.
But if they were discarded, how can you?
Yes, I understand that the analysis is limited because you cannot.
If they were discarded, they were
Yes.
discarded. And
Yes, but those kidneys were transplanted. So these are, for any reason, kidneys that were the perception that it would work. And that's the reason the biopsy is debatable.
okay, at least I get a little something here. That's like scoring a goal in Brazil at the time the goal was two rather than one.
For instance, the incidence of delayed graft function in that population is 25%. Among our donor population is 60%.
Yeah, but you don't use pumps.
Yeah, but the pump wouldn't change that.
You don't know.
We did it
We did a
show.
study on that.
We did a study.
With the pumps?
Yes, we did. And the question is that if you take a expanded criteria donor, the donor multiplication was late and donor maintenance was not adequate. On top of biopsy findings, perhaps this lack of association will disappear.
Yeah, but those are kind of variables that you may control the donor management. There's something
We can.
you can, but it could be improved. That's what you're alluding.
It's very difficult because we're talking about 100 different hospitals.
So there is no uniform criteria to approach the management of a.
No.
But that's a very good point. We did do a survey of the Critical Care Society of India. They have 12,000 members. We only got 120 answers, but the management was. They know how to declare brain death, but the management, DCDs, these are management. They know better. At DCDs, it's zero. So I think those are areas for improvement.
Yes, definitely.
Okay. Any other comments, Jose?
No, go on.
Okay. Any comments from the audience? Okay. So a few words about donors after circulatory determination of death. This is a review of the US data by Sunita King and Joe Kim from the University of Toronto. And you can see, if you focus on the table at the top, there is an increased risk of primary non-function on the right of 2.93% in using an expanded criteria donor and with a cardiac arrest, and 53% of delayed graft function, compared to lower percentages for standard criteria donors, expanded criteria donors, and young DCDs. So you see a young DCD would have a need of dialysis of 30.5%, which is acceptable. So what about our experience? So here I'm showing a slide with my friend Jean Chervenkov, who spearheaded the use of expanded criteria donors in Quebec, Canada, and North America. And there we were, Niels, we were in the Netherlands. We were waiting for the ferry to go to a small island where there were manufacturers of ceramics. I can't remember exactly, possibly. And so you can see, Jean asked me, would you accept this donor? I said, of course, Jean, it's only 79. And a few years ago, we became ECDs, expanded criteria doctors, with good creatinines. When I'm on call, I always say the same thing. We always have time to say no. Usually, when there is a high-risk donor, one of the reflections is, oh, should we take this donor? And we should remember that the patients waiting for a kidney transplant trust us, and that the kidneys don't grow on trees. So we need to think about those things when we say no to an offer. So this is our experience, published 11 years ago now. Nassima Ismail, who was a fellow, was the first author. And it's interesting. I will walk you through the data. The best sense of graft survival using ATG induction in all the patients and triple immunosuppression with tacrolimus, mycophenolate, and prednisone was excellent, 80% at 10 years for, this is death sense of graft survival for standard criteria donors, and about a little bit over 70 for expanded criteria donors. And that was statistically significant. You can see the numbers. Obviously, we don't have your numbers, but these are the numbers that we have. And if you look at clockwise on the right, panel B, if there was immediate graft function, as Niels defined, there is no difference in death sense of graft survival at 10 years. Maybe with higher numbers, there could be a difference, but you can see the lines are pretty close. This is 80% and a bit over for expanded criteria donors, 80% death sense of graft survival. Then, if there is delayed graft function, panel D, it's bad for both. It's bad for both, but 60% death sense of graft survival at 10 years, which is not that bad compared to dialysis. And panel C, with there is slow graft function, then there is a difference. So we hypothesized that perhaps expanded criteria donor kidneys are more susceptible to the ischemia reperfusion injury. So the message is that at our institution, the difference between standard criteria and expanded criteria donors is mainly observed when there is low graft function. Otherwise, there is no difference. Should we use donors with acute kidney injury? I know you do, right? You take them all.
Yes, we take those.
Excellent.
Even with creatinine over 10.
And then you do the biopsy, but then we talk about that. So, okay, so this is a donor, 49, blood group B, anoxia, creatinine up to 700 in micromoles. My father's dose of Lasix, 40 milligrams per hour, 1 gram per day. The GFR, sometime prior, was 88, normal ultrasound, normal urinalysis. So we considered older. We could perhaps have considered any age, but there was a commitment to take a risk, quote unquote. People who were on dialysis, as you can see, 2.5 years, almost 20 years after a liver transplant, and another person who was on dialysis for 1.5 years, but listed for 2.5 years. So blood group B, as I said. So you would accept this donor. So we did accept the donor. They did well. A week after, they were both off dialysis. I'm following one of the recipients, the one with the liver transplant. Now it's 5 years, and the GFR is over 60. But there is that in the literature that makes you think. And some people, it's important to be updated and to think about it. This is a paper from the UK, and I will walk you through the paper. So here you can see that graft survival was different at 1 year. The top line, the solid line, are kidneys without AKI, and the dotted line, kidneys with AKI. But it's interesting to see what the axis look. It goes from 80 to 100. If you start at 0, this gap would be very, very minimal. So yes, there is a statistical significant difference. What about DGF and PNF? So if you look at the stages of AKI, those with AKI stage 3 have a risk of DGF of 55%, which is in keeping with the literature. But then, if you look at PNF, 9%, and for some time, I was a little bit concerned about that value, but I got relief not long thereafter. Why? Because there was another paper. I will talk about that other paper. But again, if you look at kidney function, there is a decreased kidney function at any time in recipients of kidneys with AKI compared to those without AKI. And I got relief when there was this paper published a year later, looking at a longer follow-up. This is a paper from the States with a follow-up up to 3 years, and you can see the top line in red, AKI stage 3 compared to no AKI, same results. And it was a composite outcome of all-cause graft failure, GFR less than 20, or redo transplant. So that was reassuring. This is a more recent paper that was published in May of this year. So I added these slides yesterday. And these are donors who require dialysis. I don't need to say much. You see both curves aligned, so no difference. And look at the numbers. So we're talking about 990 and 950. And that outcome, sorry, I'm going backwards. So the first slide is all-cause graft failure, meaning the person died and the kidney died. And here, death sensor graft failure. The person died, but the kidney didn't die, so we consider that like death sensor graft survival. This is the opposite way of putting it. So no difference in mortality. And then there's no difference in graft survival. I'm sorry. And when we look at mortality, again, no difference. So in summary, no difference in graft survival and no difference in patient survival, which is reassuring. But again, you have someone on dialysis, let's say you do the biopsy, and then you determine if you're interested or not. If we do a biopsy, we don't look at it. We never look at the biopsy. We keep it. First, we don't do it routinely, and we probably should, so we can have something to compare when we do a biopsy for cause. There is a case, and I will comment, that I requested a biopsy in the past, and I will show you why. Here you can see, as expected, the need for dialysis after transplant. Those who were on dialysis, there was a higher need for post-transplant dialysis, 59 versus 25%. Okay, so what about the donor with diabetes? What do you guys do? Some smiles. That means that you accepted once, but you didn't accept it before, right? I can see that smile, where it's coming from. Do you accept donors with diabetes?
Yes.
Of course, you do 1,000 transplants per year. So, of course. Okay, thank you. So this is data from Columbia University in New York. They are pretty aggressive. You can see at the top, the line are the kidneys that are discarded, that were discarded, 94 to 2008. The dotted line shows the ECD kidneys that were discarded. The solid bars, the black one, depicts the diabetic donor kidneys that were transplanted, and the gray diabetic donor kidneys that were discarded. So what was the graft survival? At the top, you can see the standard criteria non-diabetic. The dotted line coming underneath shows the standard criteria diabetic. And then the other two lines, the expanded criteria non-diabetic and the expanded criteria diabetic. So decreased graft survival as one may expect. But look, on the left, you see the overall graft survival. At the top, non-diabetic recipients, and at the bottom, diabetic recipients, as expected. But when you remove death, and you keep death sensor graft survival, the survival is the same. So the kidneys survive, the patients die, mostly because of cardiovascular complications that we all expect in people with diabetes. There is a more recent study by David Sawinski from 2017, looking at the US data with a large number of kidney transplant recipients, of which 8,100 were recipients of diabetic donor kidneys. What were the results? At the top, you can see that there is a 9% survival advantage if you accept a diabetic donor kidney. And who would benefit? Any diabetic donor kidney with a KDPI less than 85, so probably if it's not an ECD, and no AKI, lower KDPI, and also a non-diabetic donor with a KDPI over 85. So essentially, with a lower KDPI, it will be acceptable. There is no advantage if the candidate for the transplant is under the age of 40. And finally, anybody over the age of 40 with a KDPI less than 85 would benefit from a diabetic donor kidney. What about a donor with disseminated intravascular coagulation? Should we refuse those donors? So this is a paper from France looking at 169 kidney transplant recipients with DIC, and they were matched using the propensity score strategy, and then you can see what the results were. So in this case, I remember I had a donor with DIC, and I said, well, probably I'd like to see the biopsy, and the biopsy was fine. That's the only time that I remember that I felt uncomfortable. But then when you see a paper like this, they don't comment much about the biopsies here. But what was the incidence of delayed graft function? No difference. What was the GFR at 10 years? No difference. Graft survival at 15 years? No difference. So, in summary, ladies and gentlemen, friends, the use of expanded criteria donors results in excellent graft survival, in particular in the context of immediate graft function. The use of high-risk donors in terms of kidney function, ECD, DCD, AKI, diabetes, and DIC results in good results in selected recipients. And we believe that the use of expanded criteria donors and with high risk in terms of kidney function should be increased. I would like to thank my wife, Andy, and the McGill University Kidney Transplant team, and all of you for your attendance. The slide on the other one said obrigado.
Tendo que o Walter Garcia, vamos ouvir uns comentários da...
Oi, parabéns, Marcelo. Muito clara a tua apresentação, muito interessante para nós. Eu concordo plenamente, acho que cada vez mais a gente vai ter que usar esses doadores, é o que a gente vai ter daqui para frente. Claro que tem equipes ainda que são inexperientes que ainda vão desenvolvendo aos poucos essa tecnologia, mas acho que as equipes mais experientes já podem utilizar todos esses tipos de doadores. Nós temos a dificuldade de usar aqui os DCD, porque não é bem dificuldade, nós temos muitos doadores em morte encefálica. Nós temos mais que o dobro da Europa. Nós temos em torno de 110 doadores por milhão, morte encefálica por milhão de população. Então, talvez daqui 2, 3, 4, 5 anos a gente precise nos decidir. Mas, nesse momento, eu acho que ainda vamos usar os doadores expandidos em morte encefálica.
Vamos ver o Manfro, professor Manfro, que é em Porto Alegre também.
Bom dia a todos. Muito obrigado, Marcelo, pela excelente apresentação, né? Ela nos coloca na contingência de fazer algo que, como o Walter acabou de falar, nós não teremos muitas opções daqui para frente. Eu acredito piamente que, expandindo a oferta de órgãos, nós podemos obter resultados muito adequados para a transplantação no contexto em que nós vivemos, de uma população de renais crônicos também envelhecida, né? Na sua grande maioria, a média de idade nas nossas unidades de diálise e na lista de transplantes aumenta progressivamente. Então, a utilização desses órgãos não só é necessária, produz bem resultados, mas tem algum grau de compatibilidade biológica e cronológica com a população que nós estamos passando a atender progressivamente. Muito obrigado aí. Bom dia.
Obrigado.
Lúcio.
Obrigado, professor Marcelo. I'm addressing my question in English. I'd like to go back a previous question before the presentation, considering the parameters on pump machine, as you have a great experience using pump machine to preserve kidneys. And you mentioned that you use some parameters like resistance or flow to make decision. Which parameters exactly? The initial, the change over the time, how long you can wait or expect for change parameters to make a decision?
So thank you for the question, Lucio. I have to admit that I don't know all the details. I hear about details when there is something not going well. The surgical team handled this in detail. Sometimes the opening resistance are high, and then there is an improvement. But as I said, and I believe the cutoff is 0.4, but I don't handle that in detail. But once, if the donor would have been considered regardless of the pump parameters, we would have used it. We would use it. If the donor has many quote-unquote borderline issues and the pump parameters are not good, we may not use that donor. But it's rare that we have refused a kidney based on the pump parameters. And we rely, and we were impressed with the results of the initial papers, and there was one published in the New England Journal of Medicine. So that helped us changing our practice. But some people, you said that you have a different experience with the pumps, but because most of the issues here are related to the donor management.
Yeah.
And then the pump may not improve.
Exactly.
And so did you randomize the patients based on the donor management that is the same for all, and then into pump versus no pump?
No.
Because that would be a way of
Yeah.
answering the question if
Yeah.
if the pump may help
Yeah.
improving the suboptimal donor management, if I use those terms.
There is one nephrologist that used to work with us. Now she's in Fortaleza, and she attempts to identify risk factors associated with donor management and DGF. And it's very, very difficult because of the heterogeneity in the management of the donors among different hospitals. So we attempt to identify risk factors, but we could not really point out a few that we could improve during the organ procurement.
But let me ask you, the analysis you were involved, you performed for the study, can you tell us a little bit more in detail? Because you said that the pump wasn't useful.
Yes, we're going to give you the paper
Okay.
later on.
Okay.
So we must go home. And then I'm going to announce the next talk that will be going tomorrow, next week. Professor Roberto Manfro, he will speak about DGF next week. Professor Manfro is there. Roberto Manfro vai falar sobre função retardada do enxerto na próxima semana. E nas semanas seguintes, nós vamos começar uma sequência de seminários em farmacologia aplicada. É um assunto que no nosso cotidiano é bastante nós temos pouca informação. Durante o curso de graduação, nós temos pouca informação sobre farmacologia aplicada. Então, nós vamos fazer 8 sessões seguidas sobre farmacologia aplicada, não só relacionada à imunossupressão. Vai ser sobre diversas atividades que nós temos. A imunossupressão é um tipo de medicamento que nós usamos uma série de outros medicamentos, é isso que nós vamos abordar nas próximas 8 semanas. I would like to thank you again, and congratulations for your presentation, and thank you for coming to Brazil. And enjoy your time here. I know that you're the first visiting professor that we have in our institution.
Well, thank you so much. This is the first time I left an airport in Brazil and didn't go back to the plane to go south to Buenos Aires. So it's the first time I'm in Brazil, actually, not at an airport.
Yeah.
So I'm very, very, very happy, and the hospitality is fantastic, and it's amazing in a place where you do 1,000 transplants per year. So we really have to learn from you guys, and hope that you will keep doing what you do and even increase it, maybe 2,000.
Oh, no. Like 1,500 would be okay.
1,500. Perfect.
Thank you.